Good morning, everybody. Hope you're all having a great week and a great rest of April as it closes down. As usual, we like to give it a moment for everybody to join. I'm going to turn it over now for a few updates from Dr. Harmon. Dr. Harmon, thank you for being with us today.
Thank you, Dr. Osdelga. I just wanted to remind everyone about the Faculty Women's Forum Award nominations. This is the third annual set of awards for the Faculty Women's Forum, which is a university-wide organization. They're due May 2nd, which is this coming Monday. Yes, next week is May. It is upon us. These are the categories, and I wanted to mention that we've had a number of members of our department who've been winners, including last year, Drs. Hannah Valentine, Joy Wu, Sibel Renault, and Maya Rossen-Slater. You can see this website. I'll put that link in the chat for more information, as well as a link to the nominations. You can also do joint nominations also from your group. And please feel free to reach out if you have questions. Thanks so much. Back to you, Dr. Osdelga.
Thank you, Dr. Harmon. Appreciate that. And then I just want to briefly mention our upcoming Grand Round speakers. Christina, if you don't mind switching the slide, thanks so much. We have Dr. Michaela Kiernan, who's going to be speaking next week. The talk is going to be innovative strategies for enhancing participant retention in randomized trials. We also will have our Dr. Watala as our program director coming in person to announce our upcoming newly announced resident chiefs. So we're excited about that, Doctor. We'll be in person next week as well, and we'll be at LK 120. So that's the medical school right behind me, and it'll be in the first floor room, the one on your left as you're going down that middle hallway. So we're looking forward to seeing hopefully more of you in person as we continue to do these grand rounds the first Wednesday of the month, both in person and on Zoom as well. So if you're around, please stop by and join us in person. As Dr. Watala will be there in person, we're hoping to see a lot more of our residents in person as well this week, next week. So looking forward to seeing people throughout the year as we progress through everything. With that being said, I want to turn everything over to Dr. Angela Rogers. Dr. Rogers has been the one who organized this grand rounds today and brought Dr. Hough in to speak. Dr. Rogers, thanks so much for helping organize this. I'll turn it over to you.
Thank you so much, Errol. It's my great honor and privilege to introduce Dr. Terri Hough, who's our pulmonary critical care invited speaker for this year. Dr. Hough truly has been a breakthrough force in our field of critical care medicine, really focusing on something that a lot of us in the intensive care don't focus on, which is what happens to our patients after they leave, and has really changed the field. She did her early training at several of Stanford's rivals. She did her undergrad at UC Berkeley, and then her medical school at UCSF before heading to Penn for residency, and then spending nearly 20 years at the University of Washington, where she did her pulmonary critical care fellowship training, and then rose all the way to rank of professor before being recruited 2 years ago to OHSU, where she is the division chief and an endowed professor at OHSU. As I mentioned, in pulmonary critical care, we choose one person per year to speak in this medicine grand rounds venue. And we chose Dr. Hough really because of the impact she's had on our field through her research. She's published more than 200 papers, and again, has really changed the way we focus in our ICU clinical trials on not just can we get someone to stay alive for 28 or 60 days, but what are the factors that suggest how that person gets back to normal life, gets back to health. Things like, how do we assess frailty at the beginning of their illness? How do we even measure these things? And what's really important to our patients in their recovery? I think that's especially important for so many of us who are now thinking about long COVID after sepsis. I think we can really turn to Dr. Hough's work to understand how we should even be measuring these things. So without further ado, Dr. Hough, we're really delighted to have you here today. We're also excited to have you visit in person in a few weeks for pulmonary critical care grand rounds on May 13th. And we'd invite anyone who's interested in this field to join us there as well. So thanks again, Dr. Hough, for being here.
Dr. Rogers, thank you so much for the very kind introduction. I'm absolutely delighted to get to share the morning with you. Again, only wish that I were there in person today, but looking forward very much to being there in a few weeks. So let me do my Zoom thing. Does that look okay?
Yes.
Yeah, fantastic. All right. Well, again, good morning. And as Dr. Rogers mentioned, I'm going to be speaking about understanding and improving outcomes after critical illness. So to start quickly with disclosures, I have no commercial interests. Most of my funding is from the National Institutes of Health, from several different institutes, as well as from the American Lung Association, and then some local funding through my endowed professorship. I think Dr. Rogers has already shared my other important disclosure of potentially some rivalries. So these are the questions I'm hoping to address this morning with you. First, what are the long-term sequelae after critical illness? Which patients are at the highest risk for post-ICU impairments? And then finally, how can we improve these outcomes so that we can help our patients live better lives? So let's begin with a case presentation in Grand Rounds tradition. So I'm going to tell you about a 30-year-old man named Jason who was admitted to the ICU in Seattle a number of years ago. He was brought in by his roommate when he was having trouble waking him up, and when he woke him up, he wasn't making a lot of sense. And his roommate told us that Jason had been febrile for several days and now had just been sleeping most of the time. But his roommate noticed that he was breathing faster and faster and that he was getting more and more tired. He had a productive cough, and I noticed the roommate was coughing as well. And it turns out that he and several other roommates were sick about a week before. Jason's only past medical history was mild asthma. He was on no medications, had no allergies, no relevant family history. And his social history was that he was functional and independent. He was working full-time as a dog wrangler. He was renting a basement apartment down a flight of stairs with 3 other friends. He's a non-smoker, used occasional alcohol and no other drugs. So this is how we first met Jason. He was hypotensive, he was profoundly hypoxemic and in respiratory failure. He was making little urine and had acute kidney injury and had bilateral infiltrates as well as pleural effusions. So while this was maybe a little bit rare of a presentation for somebody so young to be coming in so sick, back in the I think this is about 2014 when Jason came to the hospital. Clearly, this is a very common presentation, sadly, today. So how do we take care of him? He got broad spectrum empiric antibiotics. He was intubated and mechanically ventilated. He was fluid resuscitated and given vasopressors. When we interrogated his pleural space, we found gram-positive cocci growing bilaterally. So he received bilateral tube thoracostomies. And so his diagnoses evolved over the first couple of days, but we recognized that he had septic shock with multiple organ dysfunction. He had acute respiratory distress syndrome, as well as a methicillin-resistant Staph aureus pneumonia with empyema and bacteremia. And here's his chest radiograph after the chest tubes were placed. So you see, Jason was quite sick. And so an important question his mom asked me, I think on day 2 or 3, is Jason going to get better? It's an important question. And I think, fortunately, that the time of when Jason presented to the hospital in around 2014 was already within a time of considerable improvements in hospital mortality for patients with sepsis and with ARDS. And so here I'm showing you populational data from Australia and New Zealand showing that between the year 2000 and 2012, hospital mortality decreased from 35% to 18%. And similarly, across a 20-year time span in the United States, Anna Kala and her colleagues in Boston found that patients with septic shock had a declining hospital mortality here from 56% to 33%. Also, this is true across patients with ARDS. This is a systematic review of both observational and interventional studies of patients with ARDS between 1994 and 2015, during which time the hospital mortality declined from 50% to 23%. So with hospital mortality as the outcome, clearly there's still a significant risk, but that's improving over time. Well, then how about his individual risk? There are a couple of studies that have looked at sort of the population health the incidence and outcomes of acute lung injury, as we called it back in the early 2000s, are all ARDS now. This is work from Gordon Rubenfeld looking across all of King County, Washington. And then a secondary study of this done by Colin Cook, who's now at the University of Michigan, where they looked at what were the key factors associated with hospital mortality for patients with ARDS. And here we see that only one of the key risk factors applied to Jason, which was severity of illness as measured by the modified acute physiology score. But age and comorbid diseases were all in Jason's favor, as he was young and had really no significant medical history. So we expected that he would survive this hospitalization, although we were certainly worried. And he did over time improve. So on day 27 of his hospital course, he was finally liberated from mechanical ventilation. On day 29, he was transferred out of the intensive care unit. And finally, on day 50, after suffering multiple complications, Jason was finally discharged home. So if getting better is hospital mortality, Jason has certainly gotten better. But is he? When we think beyond hospital mortality, has he really improved? And let me tell you what Jason looked like at the time of hospital discharge. So he was still requiring intravenous antibiotics because he'd seeded several of his joints during his MRSA bacteremia. He'd lost over 20 kilograms and he was pretty thin to begin with. He had limited mobility. So again, a 30-year-old man who now needs a walker just to walk short distances, can't go upstairs at all. And since his apartment that he shared with his friends had a flight of stairs, he was unable to go home. Jason was still struggling to sleep, and he was describing persistent shortness of breath even at rest. So the man that was leaving the hospital was quite a different man than the one who first came in. So I think that Jason's case is an example of somebody who's young without a lot of or any comorbid or premorbid diseases, who's leaving the hospital very differently than he came in. And so with that, let's start to address this first question of what are the long-term sequelae after critical illness. And here, most of the literature that I'm going to review comes for patients with the acute respiratory distress syndrome, but quite a bit from sepsis and sort of general ICU populations as well. So to begin with, the fact that Jason was not able to go back to his initial residence is very common. This is work from Mark Unruh at Duke, looking at 99 patients who'd survived 14 days or more of mechanical ventilation. And the busyness is just to suggest that it's a really complicated environment with a lot of transfers of care to which our patients leave the hospital. And that especially older patients, they may never make it home, or if they make it home initially, they may not do so independently and may have many readmissions. And Dr. Hallie Prescott at Michigan has shown us just how common readmissions are after sepsis. This is looking at the first 90 days after discharge from the hospital after severe sepsis, in which 40% of patients return to the hospital with sort of recurrent acute illness, and with new infections being the most common cause of readmission. So not surprisingly, that even those who survive hospitalization have an ongoing mortality risk in the years after sepsis. And so this is a meta-analysis of a few dozen studies showing that anywhere between 18 and 53% mortality 2 years after discharge from sepsis. So we really do need to think of our ICU survivors as a continuing high-risk population. So it's not just sort of recurrent acute illness that's a problem for our survivors. This is an early study done by Derek Angus of 200 survivors of ARDS, in which he used the quality of well-being score to try to understand both quality of life and symptom burden, and found that at 6 and 12 months after ARDS, that well over half of patients had considerable symptoms in musculoskeletal and mental health domains, covering depression, anxiety, insomnia. Similarly, fatigue and other constitutional symptoms were very common, as was ongoing cough or dyspnea. So in the years that followed that, I think really seminal study by Dr. Derek Angus, Dr. Margaret Harridge and her colleagues at the University of Toronto published seminal work on a longitudinal cohort of about 100 ARDS patients who were followed over the course of 5 years, and who really kind of examined multiple aspects of survivorship within this cohort. And she found that that patients had some significant sort of decrements in pulmonary function at 3 months, but that almost all patients improved markedly. So that by 12 months, the majority of patients had normal forced vital capacity, had normal total lung capacity, implying that the majority of patients didn't have significant lung fibrosis. And that the lingering abnormality was a sort of mild decrement of diffusing capacity, and that was the most common decrement that was seen. And so while the central tendency certainly is that pulmonary function improves for the majority of patients, it is important to remember that there is a small minority with significant pulmonary function abnormalities that endure. I had mentioned that Jason lost 20 kilograms while in the hospital, and that Dr. Harridge and her cohort found that this was very common, but that over the year that followed, that most patients regained the majority of their weight. But interestingly, in work that was led by Kitty Chan and that I did with Dale Needham at Hopkins, we used DEXAs in follow-up at 6 and 12 months for patients recovering from ARDS, and looked at both the change in body fat and in lean mass over time, and found that actually a lot of patients don't regain lean mass, even who return to previous weight. So we've talked about symptoms and we've talked about pulmonary function and weight. Well, how about weakness and physical function? And when we study weakness by using measures of strength, we find actually that the majority of patients do regain strength and kind of return to a normal range over the course of the first 6 months to 1 to 2 years. And this is work led by Eddie Fan, who's at the University of Toronto, done while he was at Hopkins with Dr. Dale Needham. And so what they showed is, I don't know if you can see my cursor, but the top line is looking at manual muscle strength testing. So this is the old British Medical Research Council grading of strength against resistance, and found that patients really returned by 2 years to the normal range. Similarly, maximal inspiratory pressure, so sort of looking at respiratory muscle strength, that improved to normal range over time as well. And similarly, most patients had significant improvements of hand grip. But what did not improve was the function, the activity associated with this. So 6-minute walk testing, the majority of patients had only returned to 60% of predicted at 1 and 2 years after ARDS. And then similarly, using a health-related quality of life measure, the SF-36, found that the physical component scale, which sort of maps to limitations in health associated with physical impairments, found also that there were persisting decrements for the majority of patients. And so there are these persistent impairments, but they're not explained by persistent weakness. And so with this, many patients develop new disabilities. These are data from Dr. Jack Awashna at the University of Michigan, looking at older adults who were in the health and retirement study. And so what you see across the 3 tables are separating patients by their activities of daily living limitations before sepsis. So the first group is no limitations, then mild to moderate, and finally severe. And then the light boxes for each category represent the number of limitations before sepsis. So in the no limitations group, we see that about 40% of patients who could walk without difficulty before sepsis now could not do so. And then patients with mild and moderate limitations before sepsis had new disabilities developing post-hospital. It's not all physical. We know that there are significant cognitive impairments that are common really across age groups. And so some of the things that that we see commonly, and we're talking a lot about, I think, with long COVID as well, are represented in patients after recovering from critical illness. Here we're looking at the R-bands, which is a global cognitive measure, and the 100% line is normal. So we see that even in the younger age group, that most patients have at least one standard deviation of decrement of cognitive impairment. And if we look at the oldest age group, that the average is such a significant cognitive impairment that it's sort of in the same range as traumatic brain injury. Cognitive health is one way that the brain is impacted, but mental health is another. In an ARDS population, we see that really the majority of patients have mental health symptoms at 6 and 12 months after critical illness. This is more work from Dale Needham's Hopkins group, where he showed that 36% of patients had significant depressive symptoms, 42% significant anxiety, 24% post-traumatic stress disorder symptoms, and that we saw a lot of overlap between these different complexes. And so when we put this all together, we see a picture of persistent impairment in health-related quality of life across multiple domains. This is back to the Toronto cohort from Dr. Margaret Harridge, looking at 3, 6, and 12 months and showing really marked impairment across all physical domains, here represented by physical functioning, physical role, pain, and general health. But also in mental health domains, particularly vitality and the ability to function socially. So perhaps then it's not surprising with this sort of myriad impairments and symptoms that only half of patients who were previously employed before critical illness return to employment in the year that follows. And this is a meta-analysis done by Dr. Joanne McPeak across a few dozen studies showing that to be the case. So these are all sort of quantitative studies. There's some really nice qualitative work done in this space as well. This is work that led by Chris Cox that we did together almost 20 years ago in interviewing both patients and family members after survival from ARDS. And there were a number of themes that we heard commonly. One was pervasive memories of critical care. The next was the sort of just the day-to-day impact of living with new disability. And with that, the issues of coping and adapting to that disability. We heard a lot about how a patient's entire sense of self changed after the experience of critical illness and impacts on relationships as well, particularly as people who felt that they were the head of the family and the primary caregiver ended up in a more dependent role. And then we're learning more and more about the pervasive issues of financial stress during and after critical illness. So let's check up on Jason. So we followed him in one of my cohort studies, and 6 months later, he was doing quite a bit better, but certainly wasn't anywhere back to baseline. He was still describing ongoing shortness of breath, weakness, and fatigue. He had trouble with memory and concentration, and was struck by these really horrible recurrent nightmares. And with that, just couldn't establish any normal sort of sleep pattern. He was unable to go back to work, both because of these symptoms and troubles I've just described, but also because his love was working with animals, and he found that being around them in enclosed rooms, that it made him very short of breath and made his cough worse. So with this, he was continuing to struggle financially and was unable to leave his parents' home, although felt very lucky that he had that option. So when we put all of these domains together, we see the construct that was put forth by Dr. Dale Needham 10 years ago now of the post-intensive care syndrome. And I suspect this is a construct that many of you have heard with impacts both on the family and on the patient. And then thinking about the primary patient domains as we've just outlined, including mental health, cognitive, and physical impairments. Now, I think as a quick aside, although maybe not completely within the thread of this talk, is asking the question, well, so post-intensive care syndrome implies that it's all about the ICU, but is it really just about the ICU? And clearly it's not. There's work going back decades, including this important study by Dr. Ken Kavinsky published in JAGS. We're looking at a population of older adults admitted to the hospital, but not to critical care, that over a third of them had new functional decline with inability to do activities of daily living at the time of hospital discharge. And this is true for disability. It's also probably true for health-related quality of life. This is a study led by Dr. Laura Feimster that I was a part of at the University of Washington, where we looked at a cohort of veterans for whom we had quality of life measures over time. And we saw, I think, two important things. One was that in the time period before hospitalization, that patients who went on to be admitted had significant declines. So they were on a downward trajectory of health-related quality of life, and that trajectory included or continued and steepened over the course of the hospitalization, but that was true both for patients admitted to the ICU as well as to the ward. So implying that at least not all of the disability or health-related quality of life decrements are specifically ICU related. And while I decided I didn't want to talk mainly about COVID today, clearly this is an important conversation in COVID. And frankly, I think that COVID is going to offer an opportunity to understand and unpack sort of the ICU and critical illness role in this, across the entire spectrum of problems that we see in this patient population. Here, for example, is a study just published by my mentee at the University of Washington, James Andrews, and his mentee, Evelyn Quinn, in which we impaneled 55 patients hospitalized with COVID, about half of whom were in the ICU. But we found that 58% developed new difficulties or dependencies in activities of daily living 30 days after hospitalization, and that was true for both patients who were admitted to the floor as well as to the ICU. We also saw a symptom burden with 69% having a significant increase in fatigue that was associated with how long they were sick, but not necessarily how severely ill they were. And, you know, I think we're seeing this even in outpatients with COVID, that a lot of these same domains that map to PICS and that we see after ARDS are also seen in patients who are only mildly ill with COVID. This is a paper just published in Influenza and Other Respiratory Viruses journal by Jin Ho Han that I and others in the IV network, of which Stanford is a part, looked at outpatients who tested positive for COVID who had initial symptoms, and then contacted them 6 to 11 months later to see what had happened across symptom domains. And you see in the first line that fatigue remained incredibly common, both mild and moderate at 6 to 11 months, even after just mild COVID. So I think this larger story about recovery from acute illness is certainly broader than just the ICU. So which patients are at the highest risk then for post-ICU impairments? So I think a really clever way of asking this was done in a study published in Thorax in 2016 by Dr. Sam Brown, who's at Intermountain Medical Center in Utah. And so he took hundreds of patients who'd been included in ARDS clinical trials and who'd had follow-up work done measuring health-related quality of life here using the EQ5D as a measure of health utility outcomes. And he wanted to know, what of all of the different factors, the severity of illness, the different treatments, which of these were associated with quality of life in our sickest of patients? And interestingly found that there was no association of any of these acute illness variables with health-related quality of life 6 months later. Indeed, the strongest predictor of these health utility outcomes was functional independence at the time of hospitalization. And the other factors that were associated were more socio-demographic, high BMI, patients who were still smoking, older patients, female patients, and Latinos were at the highest risk of lower health-related quality of life after ARDS. And so I think that really asks us to sort of step back and think about what is the heterogeneity of the different ways that patients come to us in the critical care units, that clearly not everybody is the same. And frankly, the patient that I presented today, Jason, is a minority, right? So I think Jason would fit into this top group. So you take a patient who was healthy and had a healthy trajectory before becoming critically ill, critical illness kind of hits like an asteroid strike. And so within this group, if critical illness is perhaps of lower acuity, so maybe not with multiple organ failures, that patient may recover with completely preserved function. Interestingly, symptoms may map a little bit differently. And so patients may have persistent symptomatology even if they don't develop disability. However, patients like Jason who have a very high severity of illness are more likely to develop new comorbidities afterwards and problems across these domains of PICS. And with this, may develop new functional decline, including inability to work, issues with walking, and some of the issues that we've been talking about. Now, on the other hand, the majority of patients in many ICUs don't look like Jason. They're older, they have multiple comorbid events, and it may be that this time in the ICU is not their first rodeo. And so for patients like this, even a lower acuity critical illness may leave them with significant new comorbidities, disabilities, and other impairments within the PICS domains. And at the end of which may be risk factors for death and certainly for severe disability. And that the highest severity of illness for patients like this are very likely to lead to severe disability or death. And so I think, just as Dr. Rogers mentioned in her introduction, that the way we start thinking about who patients are before they come to us in the ICU is incredibly important. And of course, this is obvious, right, to many in primary care and geriatrics, but I think this really was a new way of thinking for those of us in the ICU. So how do we think about physical function before ICU, knowing that it's such a key predictor of post-ICU function? Well, of course, it's associated with age and comorbidity, but I think one of our problems is that it can be really hard to assess in the throes of critical illness. So, both the assessment of our pre-ICU functional status and recent trajectory of function may not be information that's readily available. So clinically, what can we do? Well, we can ask about frailty. One of the important ways to ask about this is asking about gait. Is our patient still walking independently? Has their walking speed slowed? Is this associated with falls? And work that I did with Bill Ehlenbach at the University of Wisconsin and others have shown that this is an important predictor of outcome during and after critical illness. We should definitely be asking about loss of independence within basic and instrumental activities of daily living. Finding how perhaps our patients' life space has changed. Were they decreasing their activities outside of the home already before the onset of critical illness? Had they been hospitalized recently? And then starting to think about loss of lean muscle mass is also important. And there are a number of examples of studies showing us that low muscle mass or other sort of signs of sarcopenia is associated with post-ICU outcome and disability. This chart is from work recently published by James Andrews in our group at the university when I was at the University of Washington, showing associations between appendicular lean mass, that's the ALM, as well as grip strength. And number of ADL disabilities after hospitalization. Now, unfortunately, we don't have these measures for most of our patients as they present to the hospital, although it would be brilliant if we did. So I think many of us have been trying to be clever, thinking about what are other assessments of muscularity that can be done at the time of hospital admission. And one that's gaining some favor is using CT scans that are done for other clinical purposes to assess sort of muscularity and muscle volume. So these are the examples of 2 abdominal CTs cut at L3 and highlighting the skeletal muscles, where you see sort of robust muscles on the left and very thin ones on the right. And in work led by Carolyn Davis at our place, we showed that within patients with ARDS, that if you had less muscle mass in your baseline CT, that you were much less likely to be able to walk at the time of hospital discharge. So, and then what's happening to our physical apparatus while we're in the ICU? Well, there's certainly direct sources of nerve and muscle injury with multiple organ dysfunction directly, with metabolic derangements. Inactivity, we know, is really wreaks havoc on our muscles and nerves, as does exposure to many of the toxins and medications that we use in the ICU. And so in this milieu, profound weakness is really common in our ICU patients, even though it's often hard to assess, especially if our patients are delirious or comatose. But studies have certainly shown us that many patients are unable to oppose gravity at the shoulders and hips, including about a third at hospital discharge in some cohorts. What are the ICU risk factors? I think the most consistent ones across studies are the duration of bed rest, the duration of sedation, of mechanical ventilation. So sort of the longer you're in that state, the worse. And then with Dr. Christy Mitchell, we did one study in Seattle showing that patients who had more fluid overload at the time of ICU discharge were much less likely to be able to walk at hospital discharge as well. So when we think about cognitive function, I think we see a really similar story. We know that cognitive function before the ICU is again going to be that strongest predictor of post-ICU cognitive impairment, and again, associated with age and comorbidity. But, you know, like physical function, it can be pretty hard to assess how cognitively impaired people are. It's, you know, it's often unrecognized and uncharted for anyone who likes to do big data work. Trying to find sort of early dementia in the chart can be hard. And at the same time, we know that patients with declining cognitive function are more likely to show up in our intensive care units. This is work that I did with Bill Ehlenbach when he was still at the University of Washington, where we used a longitudinal study called the Adult Changes in Thought, done by the Group Health Collaborative, that measured cognitive function in community dwelling elders over time, and showed that patients who weren't hospitalized had almost no change in their cognitive scores over time. Those who were hospitalized but not critically ill had some sort of decline in their cognitive trajectory, and those who ended up in the ICU had by far the most steep loss of cognitive function, and this is even before admission to the ICU. And then here again in work by Dr. Jack Iwashna, looking at the health and retirement study, he showed that between the time before sepsis and in these older patients who were hospitalized with sepsis, and then after, that the burden and the number of patients with moderate to severe cognitive impairment increased markedly over time, from 6% to 17%. And this is even understanding their baseline cognitive status. So what's happening to the brain in the ICU? Well, goodness, so many things. Critical illness itself certainly has directly injurious aspects, including neuroinflammation and infection, ischemia, hypoxia, and the myriad metabolic derangements. We know that our ICU treatments can impact the brain, whether it's sedation, sleep interruption, or immobility. And so we see really profoundly abnormal cognitive function during critical illness, with coma and delirium being very, very common. And studies are showing us more and more that delirium and its duration are associated with longer term cognitive impairment. Although I think the jury is still out if this is a mediator. So if decreasing delirium would decrease cognitive impairment, or if rather this is a marker of sort of a brain at risk. Similarly, thinking about the mental health domains, are patients who have pre-morbid depression, anxiety, and substance use certainly are at the highest risk. Work with Dmitry Davidov that we did, about 15 years ago now. We showed that patients with depression in the Group Health Collaborative were much more likely to be hospitalized with sepsis. And other studies have shown that patients who accumulate traumatic life events are just at higher risk for hospitalization overall. So we certainly worry about the pre-morbid mental health risks as well. And then certainly the ICU is a hard place for mental health, and signs of psychological distress are really common amongst our ICU patients, whether it's anxiety, acute stress, or depression. These are difficult to measure during the course of ICU, but when it is measured, these factors have been shown to be associated with a longer ICU course and with difficulty weaning from the ventilator. And so, you know, the risk factors for the psychological problems during the ICU, again, are a history of psychiatric disease. The more functionally impaired that somebody is before critical illness, the higher their risk for mental health problems. Similarly, outpatient benzodiazepine use is a really good marker of anxiety disorders. And then, of course, always concerns about substance use. So I wanted to switch a little bit to talk and think about then, what are some of the social determinants of recovery? I've been sort of in the medical model to date, but thinking a little bit more in the biopsychosocial model of health. So we've been talking a lot about this within COVID. One of the studies that I've been hard at work at over the last couple of years is a 1,400 patient longitudinal cohort of patients hospitalized with COVID across the country. And one of the things that we've been asking a lot about is sort of financial health. And so this is an early report from that cohort called the Blue Coral cohort, where we looked at the first 250 patients 1 month after hospitalization and asked them what was going on with their financial status. And we learned that 55% had significant drains on their finances. 40% had family members who had taken significant times off of work, and about 20% of patients had already had to change their own work. So this concern, certainly in pandemic times, that financial stress is increasing. And we had started looking at this in a couple of studies before. This is work I did when I was at the University of Washington, along with Neetha Kandawal, where we looked at about 400 patients who'd been enrolled and family members who'd been enrolled in a clinical trial, and looked at sort of what percentage were reporting financial stress 2 weeks, 6 weeks, and 6 months after critical illness. And that we found that 6 weeks after hospitalization, about half of family members reported significant financial stress, and that this stress increased for patients over time, with 42% reporting this at 6 months. So what are risk factors then for financial stress? In that same study, we found that, patients reported as having female sex, who were poorer before their critical illness, and who had small children at home seemed to be at the highest risk for financial stress. An interesting part of this analysis that Neetha led was looking then at the relationship between financial stress and patients reporting anxiety in general, and found that indeed anxiety may be an important mediator of financial stress, and hopefully one maybe that could be modified. So thinking about financial stress and socioeconomic disadvantage doesn't just associate with anxiety, but in a really exciting body of work coming out of the group led by Lauren Ferrante at Yale, and this work by Jason Falvey, they showed us that if we look at what neighborhoods our patients come from, this is here using the area deprivation index, that those that come from the most disadvantaged neighborhoods actually have the highest number of disabilities after ICU when compared with patients with less disadvantage. So not just anxiety, but actual disability and functional impairment seems to be associated with our patient's socioeconomic status. Similarly, also Dr. Ferrante's work here, led by Dr. Snigdha Jain at Yale, they used the NHAT study, the National Health and Aging Trend Study, looking at hospitalizations between 2011 and 2017, and showed that across groups of pre-ICU disability, patients who were Medicaid eligible, so an indicator again of socioeconomic disadvantage, had a higher post-ICU disability count. So again, really raising this concern that this may be a particularly vulnerable group. And then in one other piece of work by this group, now not looking at so much at finances, but rather at social isolation, with this idea that, this has been in the New York Times a lot recently about how loneliness is an epidemic and affects our health outcomes. And here Dr. Falvey looked at, again, patients in the NHAT study, so about 1,000 community dwelling older adults, and looked at the association between social isolation, survival, and then importantly, disability count after critical illness. And what he found was, again, that the mean number of disabilities after critical illness was higher, the higher when social isolation was. So, I mean, this probably isn't really surprising. And some of the qualitative work that we've done, this is a study led by Katie Hochschild at the University of Michigan, along with Dr. Jack Iwashna. We found that patients really report that being with family and friends was a really key strategy to dealing with the emotional problems after critical illness. And so it goes to follow that there are going to be multiple impacts of social isolation after critical illness. So finally, let's finish up by talking about how we can improve outcomes. So I can tell you, gosh, there's a lot of great ideas about how to do this, whether it's exercise, cognitive therapy, other forms of physical therapy, nutrition, education and information, coping skills, mindfulness, ICU diaries to help people sort of reconstruct what happened during critical illness. And then finally, clinics and follow-up programs to provide sort of multi-specialty care for patients. I mean, all of these have been suggested, have really strong rationale. But actually the randomized controlled trials that have been done to date of all of these therapies have really not shown a clear signal of benefit. And so I think it really leaves us with a number of foundational questions that yet need to be answered. Which outcomes are modifiable and for which patients? What are the key mechanisms and which risk factors are modifiable? Which outcomes can we target for intervention? And then what is the timing of recovery that kind of helps us figure out when to target interventions? So there's a lot we don't know, but I think there's a lot we can still do even in this moment. So let's just talk through so quickly what a few opportunities are to improve outcomes. Well, so clearly the first is anytime we can prevent critical illness and injury, the better. So, vaccination, not just for COVID, but, for flu and pneumococcus and so many other things. Prevention of injury is something that maybe we don't talk about as much in internal medicine, but is clearly important as well. Once a patient's coming into the ICU, I think this is a key time to connect, to learn about their pre-ICU function and trajectory, and really to understand their goals and expectations. I think this allows us to calibrate, to tailor our care to patients' needs and goals, and then to start communicating early with the patient, with the family, with our plan, and making sure that we understand what expected outcomes are. And this is really important, of course. We know in older patients with significant comorbidities that the support study from 20 years ago now showed us that patients who expected severe functional or severe cognitive impairment wouldn't even want necessarily low burden treatments, which critical illness certainly is not. Once we get into the ICU and we're in the midst of the stay, we need to do the best critical care, of course, that we can. We resuscitate our patients and try to minimize organ dysfunction and try to improve their chance of survival. We need to do everything we can to minimize potential harms and complications from ICU treatments and to try to shorten duration of ICU as much as we can. And we do know how to do this. The ABCDEF bundle, for example, in which we're assessing pain, we're making sure to limit sedation and to look daily at the ability of a patient to liberate from the ventilator, using the right analgesics and sedatives, monitoring for delirium, really encouraging exercise and mobility, engaging family. We know that these work, that observational study looking sort of at implementation of ABCDEF bundles across multiple hospitals showed us that the more complete bundle performance was associated with patient outcomes, likelihood of surviving to hospital discharge, and decreased time on the ventilator. So this is certainly an important toolkit in the ICU. And we know we have a lot of work to do. This is a collection of point prevalence studies of ICU exercise showing that across Germany, Australia, the States, and Brazil, that in general, very few patients who were on a mechanical ventilator with an endotracheal tube ever made it to the edge of the bed or out of bed. So we have work to do here. We need to prepare our patients and their caregivers for transitions, whether it's transferring out of the ICU or to discharge, identifying risk for either a plateau or a decline, such as a recurrent infection, screening for new disabilities, making sure that we have really the best communication between the hospital and post-hospital care providers, and reconciling and changing medications that may no longer be needed or need to be given at different doses, perhaps with the patient's changing renal function. And then I think education is really key in this space, providing information about post-intensive care syndrome to families and patients, and making sure that they know what to expect as they leave the hospital. And there are a lot of really good educational materials out there. For example, there's a great whiteboard video done by the Sepsis Alliance in partnership with the Society of Critical Care Medicine, and handouts that are really good. And then finally, once our patients get to that post-discharge space, We need to focus on rehabilitation and making sure that we facilitate access, especially for our poorest and most isolated patients. We need to provide them with equipment, with skills to adapt to new disability. And then really, again, focusing on this idea of connection, whether it's peer support, online communities, mental health services, and financial services. And I think there's really exciting work coming within the COVID space about the use of peer support to try to improve outcomes for our survivors, which may improve psychological morbidity, increase motivation for rehab, and reduce isolation. And this is work by my colleague here at OHSU, Hough. And then finally, across this entire timeline, this is really on us to participate in research and quality improvement. There's a lot of room for new ideas, and we need to make sure that we're really doing the highest quality research to identify solutions that may be in high value. And I think there's so many opportunities to engage both patients and families in research. And so I encourage everybody to act locally to see what can we do across the pre-ICU to post-ICU continuum to improve care. So in conclusion, hopefully I've convinced you that critical illness is not just like life-threatening, but it's also life-altering with physical, cognitive, and mental health impairments that are common across our survivors. And that we have a lot of opportunities to improve their outcomes as we prioritize understanding of our patients' pre-ICU function and trajectory, as we do our best critical care for those of us in the ICU, thinking the whole time about survivorship and not just survival, that we support our patients and families, and that we really work together. And with that, I'll thank you so much for your time and attention.
Thank you so much, Dr. Hough. That was really a fantastic review. Thank you again for being here and talking to us about this so important topic. There are some questions coming in the chat, and I would encourage others to vote on those and add your own. I'll start with asking you a question, if that's okay, Dr. Hough. And I think you touched on this a lot, that obviously on the inpatient side, where a lot of us as internists focus, you know, it's the snapshot in the person's whole trajectory. And it feels like, you know, developing new methods really depends on capturing data that we're not capturing. So the first question I'll ask is, do you feel like there are places that do this well, or a survey that nurses are doing that really that how long does it take? Is there something we should be doing in our EMR so that we can even measure how frail the patient is at the beginning? Is there something that's established in your mind that could be implemented broadly but isn't?
Yeah, wonderful question, Angela. Thank you. Excuse me. Is anyone doing this well? I think some of the more integrated health systems certainly have a leg up. You know, Kaiser, for example, has more longitudinal data on their patients. Mayo uses SF36s and SF12s for both outpatients and inpatients, for example, and so they have some longitudinal data. I think two things. One is I think it'd be really important to look across any electronic health record that we're using and see what are all the different places that people are that nurses and others are being asked to input some of this information. So for example, you know, we have to input our Braden skin score, right, for the likelihood of decubitus ulcers. And so there's information in there about how mobile a patient is, for example. Our social workers are likely collecting information about what ADLs the patients are able to do. So we have bits and pieces of this across the record, but most of it is not in queryable form. So I think a few of the really key elements are disabilities as measured by activities of daily living and instrumental activities, and then elements of frailty that are right before people start to develop disability. So how fast is a patient walking? Is their gait speed starting to slow? There are actually some very nice tools in that regard. And then I think having in one place like a dashboard, for example, making it easy for the provider at that snapshot in the hospital to understand more of the trajectory. So maybe using a care everywhere, whatever interface you use, to say, oh my goodness, this patient has been hospitalized 3 different times in the last year. They've had 2 falls, and they've lost this much weight. And that makes you think about a patient in a very different way than we might otherwise.
Thank you. Mirroring that is a question from Dr. Chu that I think you brought up a bit about Kaiser, but asking whether the severity of post-ICU syndrome is different in countries with universal health care.
Yeah, that is a wonderful question. I don't know. I don't know the answer. I do know that even in some of the countries that have really led the way in understanding sort of post-ICU syndrome and care for patients, like the UK, for example, that while they have both really good pre-hospital data and have built, they've had for 10 years UK-wide recommendations and requirements for opportunities for post-ICU care, that the penetration of that to patients is pretty low, that still those services are not used by most patients. So yeah, I think that there's hope there, and I think there are glimmers of where this is done well. Joe McPeak, for example, who's a PhD nurse in Glasgow, started a program where they had patients come post-ICU. They made sure that they both had their medical care needs provided, but also worked on employment and sort of more of the social domains. And I think programs both with universal healthcare, but also really with that focus on sort of the more social aspects of medicine, my guess is they're going to have the best outcomes.
Nice. This gets a little bit at, who do you think is the right venue for this post-ICU care? Is it primary care? Is it someone's oncologist? Is it geriatrics? Is it pulmonary critical care? I know there are a lot of different models, and you also said that the evidence so far that they're helpful is not as robust as you think it makes sense that it would be. Any thoughts about how to think about designing those things? I'll say here at Stanford, we have a chronic fatigue and fibromyalgia group that's really robust and is led by ID. So there are a lot of different models. Any thoughts about standardizing those things?
Yeah, I think there are two important questions, both about standardizing and then really thinking about access and equity. I worry that a lot of the models that I've seen built across the states, that they are only available or accessible to a really limited and sort of very special group of patients. And so, people who don't live really close to the medical center, who can't wait a long time for a visit, who have to get back to work, I think that they just don't have, or that even know that these clinics exist. So I think that that's one big concern in this space. I think it's a tough one, and I think it's certainly an area that a lot of research is needed and is ongoing. I think what we don't need is one more appointment with a bunch of tests that are not necessarily actionable unless it's for research, particularly in a patient who's already connected with primary care. My gut sense is that most of this would best be done in primary care in collaboration and with rehabilitation medicine. I think that in many medical centers, rehabilitation medicine still has a very limited focus, maybe focused on patients with stroke, spinal cord injury, and trauma, for example, maybe burns. But we don't see rehab med really integrated into things like post-sepsis or post-COVID at most places. And I really believe that that's the group with the most sort of integrated skill set and other professions working with them. So my ideal program would actually be starting with primary care and then with referrals to rehab medicine. And really only engaging heavily in people like pulmonary critical care when there are specific questions about, like, maybe progressive fibrosis or advancing dyspnea related to issues with tracheal stenosis. But that in general, I don't think pulmonary critical care docs are the best place for this.
And some nice questions coming in from some primary care minded colleagues asking about whether there are models of integrating primary care more in the hospital setting. I think, like they may have a better sense for the patient's full course and trajectory.
Oh, goodness.
Even leading into it.
Yeah. Wow. I wish I could unmute and hear a little bit more. That sounds like some brilliant thoughts coming there. I've certainly seen both some studies and some models that are trying to do more integration at the time of discharge, but I've not seen that sort of push into the hospital space. Maybe more and more as hospitalists, as opposed to necessarily primary care docs, are providing the hospital care, it feels like maybe we do lose that opportunity for connection. I think, I guess a few thoughts. I mean, one is certainly making sure that we're reaching out to primary care docs and maybe even having that be more specifically within a bundle or a checklist of, how do we connect with primary care at different points along that continuum. And then in sort of as we plan what these transitions look like, thinking about engaging with primary care early instead of having, again, this be particularly ICU driven. So, gosh, it's a brilliant idea.
Thank you so much, Dr. Hough. We have a lot of other good questions that I think because it's 9, we can't get to, but if it's okay, maybe we can send some of those your way to try to circle back. I see our chair of medicine, Dr. Harrington's come off video if you want the last word, Dr. Harrington.
Oh, no, I just wanted to thank you, Dr. Hough, for being with us, sharing with us this timely information. And we look forward to actually having you on campus in a few weeks.